I'm going to try to squeeze a 40-minute presentation into 7 minutes, so you have to excuse me. I do not do water-assisted liposuction. I believe for the majority of my patients it's not practical. I'm going to go run through the slides. My concern is that majority of my patients have very high BMI. In answer to the previous panel, we do not have absolute BMI limit. However, we do have a limit on the patients who are not able to ambulate, because in my mind it's a very critical issue. If the patient is not able to ambulate before the surgery, the risk of complications, including pulmonary embolism and DVT and so forth, is very significant. I'm going to skip through all these things. The number of articles about safety of high-volume liposuction we can probably count on both hands. And I reviewed European literature, I reviewed the American literature, and unfortunately, besides the fact that 5 liters is considered to be, anything above 5 liters considered to be high-volume liposuction, really is arbitrary number. There's no significant studies to support that. However, American Society for Plastic Surgery and majority of the states introduce the 5 liters as an absolute norm. So, for example, the state of New Jersey, if I'm operating at outpatient surgical facility, accredited, not accredited, I'm not able to take more than 5 liters at a time. I routinely take between 10 and 15 liters because that's what my patients require, and that's why I provide the services at a hospital facility. So in my mind, in order to have high-volume liposuction done safely, there are 5 main pillars: safe surgeon, safe anesthesiologist, safe facility, staff, and finally the safe patient. Safe surgeon, not too much is right now described about the fluid control, and over the years I see that having good control on the fluids is very important. So we use the residual volume theory. It's maybe a little bit technical, but in essence, what happens is we take all the fluids that patient gets in through the IVs or through the tumescent fluid. We remove all the fluid that is out, which is urine output and aspirate that we remove, and then we divide it on the patient's by the patient's weight, and it gives us a kind of benchmark that if after the surgery the patient has issue with blood pressure, then if we have excess of the residual fluid, then we can give him diuretics. I know traditionally it's not recommended, but in this case it works well. Or we can give him blood. So this is the ratios that we use. I don't want to be too technical on that. The absolute number for lidocaine toxicity is considered to be 55 milligrams per kilogram. We try to stay below that. We're at below 35. What I want to consider, and especially is probably the surgeons who are starting and they're used to doing maybe lower volume liposuction, do not forget the role of epinephrine. Everybody is talking about the role of lidocaine, but we forget about the role of epinephrine because in the higher doses, it can decrease the blood flow to the kidneys and eventually result in the kidney damage. So we also watch the epinephrine level. And also, one of the recent additions to my formula was the calculation of how much fat we can remove or lipedema fat we can remove in higher volume patients. And looking at the literature, it appears that for every 2.5 liters of a high volume liposuction that we remove, the hemoglobin will drop by about 1 point. So I'm going to go to the next slide. So here's the way it works. Anything if the patient has, for example, hemoglobin of 12, and after the surgery, we're trying to keep hemoglobin above 7 to avoid blood transfusion, we really have only 5 units of hemoglobin to drop. Multiplied by 2.5, the maximum amount of fat that I can remove is 12.5 liters. So in order for the patients to have higher amount of fat removed, I really need to make sure that their hemoglobin level is higher. Obviously, then we do nutritional labs, albumins. A lot of patients who are overweight, obese, do not necessarily have proper nutrition, and they may have lower oncotic levels, which is a level of protein in the bloodstream, and it results in increased third spacing, or when the fluid gets So basically, patients with lower level of protein in the bloodstream will have more swelling in the legs and have more complicated recovery. I'm going to skip a lot of stuff. Accreditation of the facility, education of the patients. Over the years, I think the biggest improvement that we see in the surgery is having proper compression after the surgery. We tried ACE wraps, we tried garments, we tried combination of them, and I would say the best thing we found is a combination of post-surgical garments with compression wraps. Love the compression wraps from Juzo or LNR. They provide gradual compression that can be adjusted. It's Velcro-based, not as expensive as some other things. Overall complications of high-volume liposuction are pretty low. They're about 3.5% or 3.35%. Transfusion, embolism, infections in blood clots can happen, but they're very low in a safe setting. I'm going to skip that, I guess, too. You have to excuse me. A lot of things. Okay, and finally, a little controversial point. About 2 years ago, I had a patient that came to me for liposuction surgery, but about 5 years prior to that, she had breast cancer. And she had breast cancer surgery, and she had reconstruction of the breast cancer using fat grafting from the liposuction affected area. So as she told me that, I got really nervous, but I asked her how she was doing. Was she having pain? Was she having lumps? And she said she was fine. So then I had another patient who had the same story, but that was 3 years, and she was fine. And then I had my patient who had 2 liposuction surgeries. She really did not like her buttocks, and she wanted to have Brazilian butt lift. And with a great degree of scare and a few gray hair, I agreed, after a long disclosure, to do a fat grafting of her lipedema fat into the buttocks. And she's currently about 6 months out, and she has no pain or no symptoms. My point is, maybe the fat is not bad. Maybe the fat is okay, but because of location and lymphatic issues, it does not act properly. So, thanks.
All right, thank you.